Hey guys, it's Johnny from SoCal EMS. What we're going to be going over today is your primary assessment. This is going to be the foundation piece and beginning for every patient assessment that you guys are going to be doing, whether it's medical or trauma. BSI, PPE, Penman. I have my body substance isolation and my personal protective equipment. I'm going to check for Penman, which is personnel or personal safety, environmental hazards, number of patients, mechanism of injury or nature of illness, additional resources, including ALS and fire, and any need for extrication or C-spine. From there, I'm going to get my general impression. I need my patient's age, sex, level of distress, position, and any major hemorrhaging. I'm going to check for my patient's alertness using AVPU. Are they alert? Are they verbal, painful, unresponsive? And then ask my orientation questions. Person, place, time, and event. I'll check my airway to make sure it's open, clear, and maintainable. Check my breathing, my rate, effort, and tidal volume, and my circulation. For my pulse, I need rate, rhythm, and quality. And for my skin signs, I need the color, moisture, and temperature. From there, we can treat for shock and then make our transport decision to either stay in play or load and go. That was an example for you guys to see what the primary assessment should look like. We're going to break down each and every part of the primary assessment further on as we go through this PowerPoint, but I just wanted to show you an example of how it should look at full speed. Initially, it might be a little bit difficult, but as you have time and practice, it will get easier, and it's super important for you to get good at this because this is the foundation piece for all of your assessments moving forward. Whether you're an EMT, paramedic, nurse, or doctor, it all starts here. When doing our primary assessment, oftentimes we ask ourselves where to start. Well, we start the primary assessment on our approach to the patient or into the scene. So moving forward, I want you guys to use BSI, PPE before we start anything. That's our body substance isolation and our personal protective equipment. That could be gloves, gowns, masks, or eye protection or glasses. And then for your scene size up, we use an acronym called PENMAN. That's personal and personnel safety, environmental hazards, number of patients, mechanism of injury or nature of illness, any additional resources, and any need for extrication or C-spine. So personal and personnel safety. Am I safe? And do I have all of the protective equipment that I need? Do I have helmets, gloves, high visibility vests? Is my ambulance parked in a position that I'm safe to approach or go into the scene? Any environmental hazards? This is anything in the environment that can hurt or kill us, whether that's going to be a fallen tree, power lines, traffic, cars, animals, or other people that want to hurt or harm us. Number of patients, we need to identify how many patients we have so we can treat them or call for more resources if we need them. Then we have our mechanism of injury and our nature of illness. Your mechanism of injury is going to be how the patient got hurt. Were they hit by a car? Did they fall off of a roof? Were they shot or stabbed? And then we have our nature of illness. This is going to be the reason why the patient is having a medical complaint, or generally it's their chief complaint or why they called 911. We have our additional resources. Right now, I want you guys to start considering ALS and fire, but we could also call for law enforcement. We can call for electrical companies, gas companies, animal control, or helicopter or air resources if we need them. And then we have our need for extrication or C-spine. When I say extrication, this isn't always cutting people out of cars with the jaws of life. This could be as simple as moving someone from behind the toilet into the bathroom, or moving someone from a small cramped back bedroom into the living room to where we can work them, or all get hands-on for our patient assessments. And then we have any need for C-spine. That's going to be if you're suspecting a spinal injury, an injury to their neck, we have to delegate C-spine to a partner, or we can hold C-spine so we don't cause any more harm than that is already done. The next step in our process is to gain your general impression. You need your age, sex, level of distress, position, and any signs of major hemorrhaging. So we need our age and our sex, the level of distress, whether that's mild, moderate, or acute, That's telling us how sick they appear, the position that they're in, whether they're seated in a chair, they're standing up, walking around, tracking you. They could be lying supine or on their back, or prone, which is on their stomach. And then we need to look for any signs of major hemorrhaging. That's going to be any spurting of blood, any pooling of blood, and or any darkening or saturation of clothing. Now we're going to check the patient for their level of consciousness or how alert they are. We use the acronym AVPU, which stands for alert, verbal, painful, and unresponsive. So someone who is alert is someone who is looking at you and tracking you and is able to tell that you're there. If someone's alert to verbal stimulus, they're not going to address you until you say something to them. It could look something like this. Hey! And then they would look at you. Okay? Painful stimulus is where we create a painful response to the patient, whether we do a trap pinch or we pinch the nail bed. We want to see if they're alert to painful. And if they're not alert to any of those, they're considered unresponsive. If your patient's alert beyond unresponsive, we want to ask their orientation questions. This gives us a good idea of where they're at mentally, whether they're confused or they're able to talk to us and tell us what's going on in our assessment. So we have to ask them person, place, time, and event. What I like asking them is, hi ma'am, my name is Johnny. What's your name? What city are we in? Do you know what year it is? And why did we call 911? After we've checked our AVPU and gained our orientation questions, we need to check the patient's ABCs. We need to check their airway, breathing, and circulation. For airway, we assess that it's open, clear, maintainable, and if there's any need for suction, we can drop an NPA or an OPA. We can suction the patient, or if we have to, we can roll the patient on their side to assist with that airway management. For breathing, we need the rate, effort, and tidal volume. This could be full and effective. This could be shallow. This could be labored or ineffective. And then we would have to initiate our oxygen therapy or treatments to assist the patient's breathing. For circulation, we can check either a radial or a carotid pulse, and with their rate, rhythm, and quality, this could be strong and regular, strong and irregular, weak and thready, weak and irregular, depending on how the patient is doing. And then we need their skin signs, their color, moisture, and temperature. Typically, it's going to be pink, warm, and dry, or if they're suffering from shock, it will be pale, cool, and clammy. After we get our ABCs, we can start initiating our treatments. So from here, we generally address any immediate life threats and treat them as we find them or see them. So if there's any major hemorrhaging, we can do direct pressure or pressure dressing and or a tourniquet. Any airway management or airway control, we need to address the airway, breathing, whether that's oxygenation or BVM, and then we can treat for shock. So if your patient is showing signs of shock, we want to oxygenate your patient, keep them warm, and then lie them supine. After we've done our ABCs and our initial treatments to stabilize the patient however we can, we then go to our D, or decision. Your transport decision is going to be based off of your patients a stay and play or a load and go. Your stay and play is going to be patients that are stable enough for us to continue our assessment, or if there's an intervention that we can do to stabilize or fix the patient. Versus your load and goes are going to be patients who have any issues with their mentation, their airway, breathing, or circulation, or that they're showing signs of shock. This can also be known as your sick or not sick, or your stable, unstable. All right, you guys, so we've done the quick down and dirty with your primary assessments. Once again, this is the foundation piece for all of your assessments, whether it's medical or trauma, and no matter what level of training you're at, whether that's EMT, paramedic, nurse, or doctor, or moving forward, okay? This is designed to be quick and simple. You're designed to address any immediate threats that you might see, treat the patient as you see them, and then continue your assessment moving forward.